Morning and welcome to this YouTube channel of Pain Free Partha. Today's talk is about aortic regurgitation, the very basics only. I'm not going to talk high-fi. And this aortic regurgitation is more oriented towards anesthesia. Now, what is it actually? Aortic regurgitation, what is it? It is an inadequate closure of the aortic valve during diastole. The LV pumps, the valve opens, it ejects. The valve closes and diastole happens. Now, if it is not able to close pakka in diastole, and there will be a leakage or tracking of blood into the LV from the aorta. This is what is called aortic regurgitation. I don't use aortic incompetence because even a stenosed valve is incompetent. Okay, so we will proceed with the terminology aortic regurgitation. So how far is the prevalence? It may be from trace to moderate. It may be from 13% to 8.5% in women. Now, I am again telling, now you see this is the normal. Now the LV blood ejects into the aorta. The valve closes pakka. And here you can see the LV is ejecting and in the diastole there is a trickling of blood. This is fails to close, allowing blood to leak backward. Now, what is the cause of aortic regurgitation? It may be a primary valve disease or an aortic root disease. Primary valve disease is calcific, congenital bicuspid valve, rheumatic, percutaneous valve dilatation. We have done something. Takayasu, arthritis, people see all these chronic autoimmune joint disorders. No, many persons will have valve disorders. Primary aortic root disease due to old age disease, chronic severe hypertension, the annulus dilates. Now I am again going. There may be an aortic, this is the LV. There may be an aortic valve problem, or there may be a dilatation of the aortic root. If this dilates, this also dilates, so regurgitation happens. Now this is what is valve diseases and aortic root diseases. This is one type of classification. We will go on to the next type. When it will be acute, when there is an aortic dissection. See the green, aortic, infective endocarditis, acute AR. Chronic AR will be in chronic connective tissue disorders, rheumatic heart diseases, congenital and degenerative diseases. It's a chronic AR. Aortic dissection, aortic dilatation, infective endocarditis, and acute AR. Now, what are the clinical symptoms? We will go slightly more towards chronic AR because acute AR is relatively rare for us. Chronic AR gradually, sometimes over decades. There may be dyspnea, orthopnea. What are these things? These are all backward symptoms. Sometimes they may have palpitations. This sounds arrhythmia. There may be head pounding because there's increased systolic pressure. Nocturnal angina can come because in the night heart rate decreases. If the heart rate decreases, diastole increases, the pressure falls, the coronary cannot fill up. I will again tell you. But these symptoms are relatively rare without LV dysfunction. Mostly they proceed without symptoms. Chronic AR will proceed for a long life without symptoms. Now we will go to the pathophysiology. This is the normal thing. The aortic valve is leaking. Okay. Aorta to LV blood is coming. Now we have LV. There are two sources of blood. From the LA it is coming. From the aorta itself coming. So the volume increases. If the volume increases, what happens? There is an eccentric hypertrophy and there may be a volume rise. Volume rise, eccentric hypertrophy, and there may be some pressure rise little later on. The pressure will not rise as a concentric hypertrophy of aortic stenosis. So this is an eccentric hypertrophy. Dilatation, volume overload, not a pressure overload. Dilatation, hypertrophy, and there is an increase in pressure. Now, if we have more blood here, I will again put the catapult theory. If you put the catapult tuck, and the stone will go to more areas. That is what is called the Frank-Starling law. So more blood, more stretch, more push into the aorta. That is why the systolic BP rises. The diastole chat regurgitation. So this 80 may become 60. This 120 will become 160. Now you see here, systolic is risen because more preload and pushing. Diastolic is decreased because regurgitation, TERAC. So pulse pressure, difference between these two increases. There is something called Laplace law. Stress is equal to pressure into radius by 2 times the thickness. Now there is a dilatation. Radius rises. There is some rise in pressure. So thickness is also raised. So there may be an LV stress. Slightly increased stress in aortic regurgitation. Because the radius is also increasing. Pressure is also increasing. Thickness is also increasing. Now you see here, now the aortic regurgitation, LV dilates like this, thickens like this, pressure rises, volume rises, slowly it is transmitted to the LA, it is transmitted to the pulmonary veins, relating in backward symptoms of pulmonary congestion. Now you see here the aortic regurgitation pathophysiology again. Now we will start from wherever it is. We start from here. There is an isovolumetric relaxation. So here you can see the volume is slowly rising. The ventricle is relaxing, not like flat like this. Because of the leak, the volume also rises. Now this is filling phase. The filling is more because it comes from the aorta, it comes from the MV. So the volume is more. If the volume is more also, the pressure does not rise much like in acute AR. If it is going to be an acute AR, the pressure rises like this. But here, the LV is ready by way of thickness, by way of better contractility, by way of little more eccentric hypertrophy. Now you see, this is isovolumetric contraction phase. There is no change in volume. But here, the volume is changing because of AR. And you see, this is the ejection phase. Come back to isovolumetric relaxation, filling, isovolumetric contraction, ejection. See here, even during contraction, just because above it slowly starts ejecting. And again, during the course of relaxation, it fills up. This is what is called the PV loop of aortic regurgitation, which is chronic. Now, if you go on, see now here, backward symptoms are going on, the pulmonary congestion is there. If it goes beyond that, the LV fails and the forward output is decreased. That is in severe LV dysfunction. They may have forward symptoms. Now I have told this special thing is nocturnal angina may come. Why? Because here the LV is big. The LV is thicker. It needs more oxygen. Now it depends upon the root pressure here. Aortic root pressure to push in blood into the coronaries. If there is a leak here more, which is persistent, the aortic root pressure cannot match the coronary perfusion of a big LV. So that is why there is a nocturnal angina. Now you go back again to the pathophysiology. Backward flow of blood from the aorta into the LV, rapid fall of aortic pressure during diastole, so increased pulse pressure. Systolic rises, Frank-Starling mechanism, diastole decreases, pulse pressure increases. Peak systolic pressure increases. Now you see there is a volume overload and pressure also overload. So increased diastolic wall tension produces eccentric hypertrophy. See here, diastolic wall tension. If it is going to be a systolic wall tension in AS, it is going to be concentric hypertrophy. Now you see here an increased diastolic tension. If it goes on, increased LA pressure and goes on to pulmonary edema. There is a difference between acute and a chronic. Now you see acute, patient has got infective endocarditis. LV is not ready. LV is not dilated like this. It is not thickened like this. So it transmits high pressure. It transmits pressure and patient develops an acute pulmonary edema. Or again, I am telling you again, it will come again. Now you see the LV is not ready. The pressure rises. The compliance curve is like this. But you cannot see the compliance curves come like this. Only in decompensated it will go like this. In compensated it will go like this. So the LV is not ready. Now if you want to go it again, this is the aorta. This is the LV. This is the LV. Now you see this is almost normal. 120 by 10. Here it is 5 has increased slightly to 10 LA pressure. Now 128. In chronic AR, what happens is systolic rises. And the diastole also rises, but not much. Here the aortic LA pressure also rises slightly. But 160, 50. Maintenance is there. Here if you want to see, if it is 40, gone. LA pressure is 40. But anyway, it will try to push something. Here, it cannot push. The ventricle is not ready. The BP comes down. The LA pressure becomes 40 in acute, severe AR. There are so many signs, Austin print member, Becker's signs, because everywhere we can see the pulsations in the retina, in the uvula, in the face, in the heart, everywhere, lower extremity, spleen, uvula, so many things. All these things are due to systolic BP is high, there is a sudden fall, diastolic is low. That is why all these so many signs are happening. Now you see the LV is dilated. So the apical impulse automatically has to push laterally and inferiorly. Atrium may be dilated and there may be atrial arrhythmias. Now we can see a systolic thrill because aortic regurgitation, high frequency may be palpable because large stroke volumes. Now you see there is something in murmurs. A murmur can be an abnormal flow through a normal valve. That can happen here. It is not stenosed. Aortic is only regurgitation. But here the valve verifies, for example, take it as 3. Now 70 ml should go, but 150 ml goes. Again there may be murmur, but valve is not stenosed. So S1 is normal, S2 may be increased, high frequency, blowing, decrescendo, diastolic murmur. A third intercostal space, left sternal border, end of expiration, patient is leaning forward. All these things, what happens is, it makes the aortic valve and aorta close to your chest. If you are doing end expiration and leaning forward, your aorta is close to the chest. That is why you get a diastolic murmur, which is better appreciated at the end of expiration and patient leaning forward. Most important thing is they may not reflect the severity. Patient may be severely symptomatic. Sometimes it may not be very severe. This is a unique feature of a chronic AR. Now these are all this. Now we know what is AR and what is the etiology of AR, which can be divided into an acute or chronic, or it can be due to a valvular or a supravalvular or aortic, or you can go into the acute and chronic pathophysiology. What are the clinical symptoms? Then we go to so many BIS variants, pulse, bus variants, so many things, pulsations everywhere. Clinical signs of early decrescendo diastolic murmur. Then we go to ECG. There may be a left axis deviation, LVH, volume overload. There may be a T wave inversion. If this T wave inversion is so symmetrical and significant, then ECG itself tells there is some LV dysfunction. Because EF is normal. EF is not affected in acute, which is chronic AR. With severe AR, the central jet bits 65% of the LV. When the regurgitant fraction is more than 60 ml, effective regurgitant orifice is 0.3 or more. The fraction is more than 50. That is what I tell always. Regurgitant orifice more than 0.3. When the regurgitant fraction is more than 50%, then this regurgitant is dangerous. Now sometimes here product falls. Even the descending aorta may show a flow like this. This becomes severe. So this we have diagnosed as AR, and cardiac MRI catheterizations may confirm these things. Catheterization is not practiced for the sake of diagnosis alone. Now, what are the treatment options? We have ARBs, ACEs, and diuretics. What do? They decrease the afterload. Now, the LV is pumping. The pressure here in the aorta is less. More blood will go there. So regurgitation is less. So that is what is the principle of decreasing the afterload in aortic regurgitation. The treatment of choice is AVR. Severe symptomatic chronic AR, asymptomatic with LV dysfunction. Symptoms should be attributable to aortic regurgitation. See, because it may be an aortic regurgitation with dyspnea, there may be a coronary artery stenosis, or there may be a CHD, or there may be a severe anemia. So symptoms should be attributable to AR. Non-cardiac surgeries, aortic regurgitation, severe symptomatic valve replacement. Asymptomatic, then you go for LVEF. EF is normal, then go for non-cardiac. Other cardiac surgeries, aortic valve replacement. Other cardiac surgeries, aortic valve replacement. This is how it is. So severe A, symptomatic aortic valve. Severe A, even if it's asymptomatic, LVEF is less than, go for aortic valve replacement. Intra-aortic balloon counterpulsation is one disease that is contraindicated, because if you increase the afterload, danger. Most asymptomatic patients with severe AR can undergo urgent non-cardiac at an acceptable risk. You need to carefully monitor the patient. You need to control the afterload. You be positive in fluid balance. Then most of the asymptomatic patients, even severe AR, also go ahead. Elective is generally reasonable, asymptomatic moderate. Normal LV systolic functions. So major society guidelines, what they say is, go ahead with non-cardiac surgeries if the patient is asymptomatic, even with normal LV function, major or minor AR also. Severe AR, LV systolic function is normal. Patient is asymptomatic, then go ahead with non-cardiac surgeries. Severe AR, the patient is either symptomatic or LV dysfunction is there, go for replacement first. The anesthesia concerns is to maintain the forward flow, decrease the regurgitant volume. That is what is the problem. No, we have regurgitation. We want to decrease the regurgitation. Normal or high augmented preload. Give little higher. Late is little higher. Keep it at 90-95. Rhythm is sinus if possible, but the rate is more important. What is the difference between AS and AR? AS, rhythm is important. AR, the rate is more important. It doesn't mean the rhythm is not important. Rhythm is important. But AS, rhythm, in AR, rate. Contractility, maintain or augment. Afterload, keep afterload low to promote forward flow and decrease regurgitation. In severe ARs, you can have invasive lines. What are the hemodynamic goals? Now we have preload, heart rate, contractility. Yes, yeah. This is what is called the cardiac grid. What we should do? Preload, increase. Increase the preload. Don't go into hypovolemia. That is dangerous because There is no blood coming into the alveoli. Heart rate is slightly increased. This has been slightly countered, but people say keep it at 90-95. Increased heart rate, decreased diastolic time. If you decrease the diastole, the problem is diastole. There is a regurgitation in diastole. If you decrease the diastole from point so-called 6 seconds to zero point 0.4 seconds, then it is possible that you have less regurgitation, more forward flow. Contractility maintained. Must be maintained. Use of beta agonist or PAS can increase stroke volume through a combination of peripheral dilatation and increased contractility. That is what is important. We need to have what you call as inodilators. It has to have contractility and it has to dilate outside. This is called inodilators. That is what is important to maintain cardiac output and decrease regurgitation in these patients. SVR, decrease SVR. Afterload reduction is helpful in improving forward flow. PVR, if the patient goes into chronic AR, LA is dilated, more pressure, back pressure to pulmonary. Yes, maintain. Heart rate is on the higher side, 90 to 100, decreased diastole and decreased regurgitation. If you want to proceed with the GA or spinal or epidural or segmental spinal or neural blocks, that is okay. But we should have the mind to maintain the cardiac grid. Fentanyl midazolam is okay. Even glycopyrrolate is okay. You see here, I always give start with glycopyrrolate in the air. Start, give the rate, maintain. So if you have fentanyl and then start giving your vecuronium, that is not good for aortic regurgitation. Brady is dangerous. Sevoflurane, not much myocardial depression and no steel. So I will put fentanyl, midazolam, glyco. If possible, avoid vecuronium. SVR reduction may be acceptable, but the problem is if you use spinal, there is vasodilatation. We like arterial dilatation, but we don't like venous dilatation because arterial dilatation, afterload reduction, AR super. But venous dilatation, decreased preload, AR dangerous. So if we maintain a good preload and then give a neuraxial blockade without bradycardia, then you are in. Ephedrine and mephentermine is okay because phenylephrine may cause bradycardia. That is the most important message I want to give. I have ended up in problems. Don't give, because this patient is a heart disease, don't give phenylephrine. Heart disease, phenylephrine, nothing. Aortic regurgitation, give mephentermine. That is better because slight heart rate increase is that we want. As soon as we give spinal, rate is going to decrease, BP is going to fall. Give meth, increase both. Peripheral ness blockage, yes. Less hemodynamic changes, yes. Think of pregnancy. What happens? Heart rate rises. SVR is reduced in pregnancy. Preload is increased, more cardiac output. Contractility is better. So what do you want? So that is not the answer. That is not the answer. Make all AR patients pregnant. That is not the answer. What I want to tell is pregnancy is good for AR. Any anesthesia is possible, but think about the heart rate. Heart rate is around 90. More fluids and keep little normal or higher preload. You reduce the afterload. If you reduce the afterload, the forward flow is better. Regurgitant fraction is less. There may be an increased PhD, so decrease PhD. So what are the things? Avoid hypoxia, avoid hypercarbia, avoid nitrous oxide. Maintain the contractility. Don't use direct myocardial depressants. Thank you all. Thank you all for my patient listening.